For head and neck imaging, I'll just be highlighting one very specific part of the discussion in the book. So, when we talk about head and neck imaging, this involves other things in the head except for the brain parenchyma. No? So, this includes the orbits, the paranasal sinuses, the neck spaces. So the suprahyoid head and neck can be divided into these spaces. You have your nasopharynx, oropharynx, oral cavity. Then in the deep anatomy, you can subdivide them into these spaces. So one space that I really want you to know is the parapharyngeal space. So this is best seen on eggshell cuts of the brain, no? Whether in CT or MR. And it's an important landmark for mass effect in the deep phase. So what does that mean? It means that any displacement of the parapharyngeal space will guide us as to what pathology is actually involved. So the parapharyngeal space is this yellow-orange region. So basically the concept is that if for example, you're dealing with a pathology that involves the parotid space, your parapharyngeal space will be displaced medially. If you're dealing with pathology in the carotid space, then your pathology is, your parapharyngeal space will be deviated laterally. So any movement of the parapharyngeal space will guide us as to where the pathology is localized. And with that, we can narrow down our differential diagnosis. So these are the spaces and their contents and what possible pathologies we might be dealing with. No? So the parapharyngeal space is basically fat containing. So as I mentioned, for example, if we note that the parapharyngeal space is deviated medially, so we're looking at some of the parotid pathologies. So we could narrow it down to this 4. So that's how it works. Basically, that's how to identify the possible mass that you are dealing with in the next spaces. For our last topic in neuroimaging, again I will go very quick on non-degenerative disease of the spine. So first, let us differentiate between myelopathy and radiculopathy. So this basically the compromise involves either the spinal cord or the spinal nerve, and one of this is urgent. Myelopathy is urgent because if it's severe, high significant deficits may occur if it's more than 24 hours. Unlike in radiculopathy, usually the short you can have conservative treatment since there's little risk in these cases. So in terms of neurologic findings, in myelopathy, you'll have ataxia, incontinence, and Babinski sign. In radiculopathy, you might have weakness or diminished reflexes in specific muscle groups or dermatomal sensory deficits. So basically, we see radiculopathy more often, and the preferred imaging modality in this case is CT scan because we can see most of these pathologies easily. For myelopathy, we really need to do MRI because we have to look at the signal of the spinal cord, and we cannot appreciate that well on CT scan. Then for tumors, we again similar to the head and neck spaces, knowing the location or the specific part of the spinal lesion that is involved will narrow down our differential diagnosis. So basically, it can be divided into three categories. First is your intradural intramedullary. Next is your intradural extramedullary. And C is your extradural. So to make it easier for you, or just remember that when you say intramedullary, it's similar to intraaxial in the brain, and when you say extramedullary, it's similar to extraaxial in the brain. That is why the most common pathology in extramedullary is also your meningioma, same as in extraaxial tumors of the brain. For intramedullary, our primary differential diagnosis would be ependymoma and astrocytoma, since basically these are the cells involved in the spinal cord, and it's sometimes very difficult to differentiate the two. So for ependymomas, this is the most common spinal cord tumor. As you can see, the signals are seen inside the spinal cord. So these lesions cannot be seen on CT scan. Then for extramedullary, our prototypical tumor is the meningioma. It's the most common, and it will present outside the spinal cord. So here you can see this is on myelogram. You have this is the spinal cord, the one tubular density going down, and you have a very well enhancing tumor that compresses the spinal cord anteriorly. So that's it. Very quickly, I just showed you the more common pathologies that you see in the spinal cord. If we discuss it more extensively, it might just confuse you. So I selected just a few examples just to give you an idea that radiology also tackles these cases, and the primary imaging modality would be CT scan and MRI for neuroimaging, whether in the brain or in the spine. So it's important that you know what imaging modality is best for your patient. This is very a lot of factors you must be able to consider, including the availability, the price, the specific pathology that you are looking for. Again, it's very important that you have a very good clinical history and physical examination of this patient, so that even without imaging, you already have a narrowed down differential diagnosis. Because as you've noticed, or I'm sure, hopefully, you have noticed that in radiology, we rely a lot in the clinical aspect also, and we won't be able to give you everything. Like you can't just say that I will do an MRI because I think it's the highest level modality and all the pathologies will be seen. That's not true, no. So you must know what you want to look for, so that we will be able to help you and guide you as to what modality to use and how to approach these cases. Because sometimes it's really a case-to-case basis. I guess that's it. That's the lesson that I want you to really absorb in neuroimaging. So thank you for listening.